Hi, I'm Dr. Tristan Dodds. We've gathered a series of questions from GPs about the diagnosis and management of melanoma, from biopsy techniques and interpreting histopathology to long-term surveillance. There's a lot to cover. Let's get started. Okay, so this is an interesting one. Is the Clark level important? So the Clark level is a measurement of the anatomical layer that the melanoma has penetrated into. It's largely been surpassed by the Breslow thickness. It's not as reliable or reproducible as Breslow, and so you don't tend to see it on reports as often, and it's not incorporated in the staging category. Okay, so this one's very important. What information should I provide on the pathology request form for an atypical pigmented lesion? So pathologists really appreciate if you can provide the size of the lesion and if there's been any history of change. Another really important thing is if there has been a previous biopsy done or trauma to the lesion, because those features can cause regenerating or recurrent nevi, which can lead to changes that mimic melanoma and lead to a false diagnosis. The last thing that is important is if you can let us know if it's an excisional biopsy of a lesion or if it's an incisional biopsy of a larger lesion, which we don't normally recommend. Okay, so this is another interesting one. What if there is a strong suspicion of melanoma, but the histopathological diagnosis is reported as a nevus? So the first thing I would recommend is to pick up the phone and call the pathologist. We're always very keen to hear from the clinicians and have good clinico-pathological correlation. The first thing that we'll probably do is some deeper levels into the paraffin block to see if we can find any more atypical areas that explain the discrepancy. It might just be the case that we can explain the discrepancy in another way. For example, a deep penetrating nevus arising in a pre-existing nevus actually may look like a melanoma clinically, but under the microscope is completely benign. Oh, I really like this one. What if there is a particular area within a pigmented lesion that I'm concerned about? So one thing I would recommend, if possible, if you can send the clinical images to the pathologist, and if there's a particular area that you're worried about, to annotate that image so we can hone in on that to make sure we're looking at the right part of the lesion. Another technique, which is not used very often but can be quite useful, is called punch scoring. And in this situation, you can use a punch biopsy instrument to lightly score that particular area that you're worried about. The pathologist can then see that scored area under the microscope, and so we can be sure that we're looking at the right spot. Okay, so this is a common query. For a patient with a thin, example 0.5 millimeter invasive superficial spreading melanoma, what are the guidelines for long-term surveillance and skin checks? So for thin melanomas, generally one would recommend follow-up at least annually. But for a thicker melanoma, for example, a stage 2B or above, they tend to recur more often in the early stages. So it would be better to follow up these patients with skin checks every 3 to 4 months for the first 2 years, and then 6 to 12 monthly for the 3 years after that. Another thing that's great to recommend is for the patient to perform self-examinations every 3 months. Okay, so this question is the most important from the pathologist's point of view. What type of biopsy should I take? For atypical pigmented lesions, we recommend elliptical excisions with 2 millimeter clinical margins. The reason for this is because two of the most important parameters that pathologists look at are size and circumscription, and we can't do that with partial biopsies. We don't recommend partial biopsies because sampling errors may occur. For example, you may miss the melanoma arising in a nevus. Partial biopsy may also underestimate the Breslow thickness. In cosmetically sensitive sites, it's not always possible to do an elliptical excision. And in those situations, a punch excision or a shave excision may be appropriate if the clinician feels the entire lesion can be removed. We would only recommend incisional biopsies in certain circumstances. For example, if you suspect the lesion is not melanocytic, such as a pigmented basal cell carcinoma, or if it's a very large lesion in which you want to perform mapping biopsies. Okay, so this is a topical one. What is something that excites you about the future of healthcare? So in terms of melanoma, the advent of immunotherapy and targeted therapies have revolutionized the treatment and outcomes for melanoma patients with advanced disease. So it's very exciting to see how this will improve as time goes on. The other thing is digital pathology and artificial intelligence. Whilst daunting from my point of view, certainly has the potential to improve the accuracy and the efficiency of histological diagnoses and will improve patient care in the long term. Well, that's all our questions for today. I hope this session gives you practical insights for managing melanoma in your patients. By thinking through these questions and scenarios and applying guideline-based recommendations, you can approach melanoma confidently and support timely, effective patient care. Thanks for watching.